This session refers to data for quality improvement and how it differs from other improvement work. I'm Sam Machin, the Improvement Facilitator at CLCH, and I'm part of a wider quality improvement team who are here to support all improvement in the organisation. This session aims to introduce the concept of measuring for improvement with the overall objective of understanding the differences between measuring for improvement and measuring for research. This next slide will identify three traditional types of improvement that may happen within healthcare and identify the nuances between these three different types of improvement. The first is audit, which really looks to seeing how a team or a service is performing. It's a predefined time, normally a time in the month, so the first Monday of every month, where a specific performance audit will be carried out. So this may be, for example, the amount of dose emissions there were in the last 24 hours. And normally this sort of point prevalence audit is referred to and compared to a either organisational target or a divisional target. Research, on the other hand, is looking at developing and discovering new knowledge. It is looking to either add to affirm research that's already been done or to challenge it and oppose different ideas within a research base. QI, on the other hand, is looking at how do we best improve care today. And a really important aspect of this is the specificity of it saying today. We're looking to try and improve quickly and iteratively to a specific group of people, and we're not trying to improve the knowledge base. We're just trying to improve the outcomes of a particular intervention. So looking at research and quality improvement a bit more deeply, it is important as it identifies the key differences where some people actually can see research and quality improvement as synonymous with each other, but seeing them and their differences is key in understanding what sort of improvement work are we doing and how does that affect the data in which we're going to be collecting. So the aims of research really is to increase and generate knowledge about a particular subject, whereas quality improvement is much more data driven. It's guided to bring out immediate and positive changes to healthcare in particular settings. So to give an example, if after a monthly report a team realises that they have an unfavourable amount of pressure ulcers for patients that are getting it post-admission, this may mean that they're now guided to start a quality improvement project with the underlying aim coming from the data, which is identifying that they need to do something to improve their services and the patient outcomes. The timescale of research is much more extensive, it's very labour intensive, and this is due to its systematic nature. Whereas quality improvement can be quicker. It involves many cycles of change, which my colleague Sid has discussed in a previous session on PDSA cycles. The transferability of research is key in its distinguishing features compared to quality improvement. Research is designed to provide generalisable knowledge that can be transferred to other similar settings, whereas quality improvement is usually institutional, specific setting focused. This isn't to say that we can't learn from other quality improvement projects, but it's important to note that what may work in one service may in fact not work in another service. The methodologies for research is very expansive. There is qualitative, quantitative and mixed methods methodologies and underlying methods for these methodologies. But quality improvement really benefits from a focused methodology, which is looking for the model for improvement. For example, at CLCH, this is the model in which we use, which in a previous session from my colleague Sid, this is further explained. And in terms of ethical approval, none is needed for quality improvement, but it is always needed for research. So in terms of the differences within the data that you'll collect for quality improvement versus research, data for QI usually refers to one single organisation, whereas research usually rests from multiple organisations. And this kind of has very important implications in terms of logistics. So one single organisation, the data you get, even if it's from different services within the organisation, is likely to be formatted in a similar way if it's being collected by a centralised system. Whereas with research, if you're getting it from different organisations, there is a lot of different systems that may be used that aren't the same, and thus aggregating reports may be fraught with difficulties in terms of it needing to be cleaned and coded. Whilst I identified before that QI doesn't necessarily need ethical approval, data still needs confidentiality safeguards irrespective if it's for QI or for research. And this identifies ensuring that data is anonymised and stored appropriately. Data for QI will also focus on specific groups of services, teams and interventions, whereas research will focus on broader or more abstract concepts. To give an example, a single organisation that wants to ascertain the effectiveness of videotapes for diabetic education across several of its clinics may use a QI methodology. But if someone wants to understand how multiple organisations, or their own contexts and cultures, are interested in understanding the effectiveness of videotapes for education more generally, then research fits the bill a bit better here. In this scenario, the fact that there's multiple organisations and they're trying to understand something more conceptual, the idea that education and how it's affected by videotapes, means it lends itself to more of a research-based focus. But fundamentally, the presentation of data in QI and research is very different. We see here a traditional depiction of quantitative analysis for research, and circled here is the p-value, which is very symptomatic of research and quantitative analysis. So the p-value is not something that this session will focus on, but it's important to identify this refers to the statistical significance, which is determined by an analyst or the researcher, and it identifies to what level the results of the data are not explained by chance alone. So a p-value of 5%, or in this case p 0.005, is usually often considered to be statistically significant. Comparing this to QI, we're actually less interested in statistical significance, and we're more interested actually in understanding variability. You see the circled aspect of this graph, this run chart, is talking about, well, okay, there are now points above the red line that have changed. Why have they changed? Is this to do with an intervention? And it's this variability and this this emphasis on sustained change and improvement from projects into how QI is focused in understanding its impact. So next steps for you, if you're interested in carrying on learning about the way in which data is used within QI, then there you can include watching the next video, which is on variation.